It's been 25 years since the Beijing Platform for Action was adopted. Since then, the world has seen dramatic changes, most notably in the last year since the COVID pandemic. While there has been important progress on some fronts, new challenges have emerged. Demographic, epidemiological, technological, and socio-economic transitions have evolved the nature and risk of drivers of women's health, their access to healthcare services, the experience of ill health, and the quality of life. Climate change, migration, and humanitarian crises are precipitating new risk factors. Rapid urbanization, greater economic participation of women, but at the same time, rising socioeconomic inequalities coupled with advances in in health and medical technologies are all shaping the landscape in which we are operating and looking at women's health today. At the same time, there is an unfinished agenda. Millions of women continue to have an unmet need for contraceptives. Adolescent girls still lack information and quality services to prevent pregnancies, STIs, or HIV. This unfinished agenda reflects the real lack of political commitment to women's health and gender equality, as well as the power of conservative backlash. COVID 19 has heightened many of women's health risks, particularly for women healthcare providers, survivors of violence, and women with unintended pregnancies, and it has exacerbated the burden of formal and informal care placed on women. Amidst this tragic impact it has had on millions of people, there is a lot of talk about building back better, drawing on lessons from failures to contain this pandemic or mitigate its impact. And one of the areas where we have a real opportunity to not only build back better, but to build back fairer is to address the issue of gender equality. So, this session will draw on the evidence and lessons on advancing women's health since Beijing to rethink how to better meet women's health needs. Based on a series of papers commissioned by the British Medical Journal as part of a joint collection with the UN University and the WHO, panelists will reflect on progress, emerging opportunities, risks, and a forward looking agenda for women's health towards 2030 and beyond. I wanted to start by introducing the panelists. So, the first panelist will be Michelle Remy, who leads the research pillar at the UN University International Institute for Global Health. She's a health economist with over 15 years of experience as a researcher and policy advisor in global health, having worked in academia, the UN system, donor development cooperation, and private consulting on the financing of health systems and gender responsive structural health interventions. Our second panelist, Asha George, is a professor at the School of Public Health, University of Western Cape in South Africa. With a gender and rights lens, she focuses on the frontline interface and governance of health services, taking into consideration community and health worker perspectives. Our third panelist is Lavanya Vijayasingham. She is a postdoctoral fellow at the UN University's International Institute for Global Health in Kuala Lumpur, Malaysia, working with the Gender and Health Hub on gender and health policy research. Lavanya's background includes biotech, biomedical sciences with a focus on pharmaceuticals and postgraduate studies in health economics and public health. Our fourth panelist is Veloshni Govender. She's a scientist at the Department of Sexual and Reproductive Health and Research, WHO, in Geneva. Her background is in health economics and health policy and systems research. Her current work focuses on strengthening the integration of sexual and reproductive health in universal health coverage policies and reforms. And our last speaker is Rachel Hinton, who works for the British Medical Journal as a freelance editor, and she has worked on the collection of papers on women's health and gender equalities that we will be discussing here today. So over to you, Michelle.
Thank you very much, Avni, and good morning, good afternoon, good evening, everyone. It's a pleasure to connect with all of you, and thank you so much for making the time to join us. So as Avni mentioned, I work at the United Nations University International Institute for Global Health. For those of you who don't know UNU, it's a think tank for the UN system. And our institute also coordinates the Gender and Health Hub, which is a platform for evidence generation, knowledge sharing, and policy engagement on what works to promote gender equality in health. So we've had the pleasure of partnering with WHO and the BMJ on this exciting series on women's health and gender inequalities to commemorate Beijing +25. And I will use my time to provide a brief background to the series. I think Avni has already touched on several points, but I'll just elaborate a little bit more before I hand over to the authors of the great papers and pieces of analyses that have already come together in this series. So Avni said it already, it's been over a quarter of a century since Beijing. Beijing brought together 189 governments, as well as 17,000 participants from all over the world, 30,000 activists, with all the diversity that these numbers represented. And at the end, there was one message, which was gender equality and the empowerment of women. Beijing was a landmark global policy framework. It affirmed that women's rights are human rights and that gender equality is both a condition for social justice and a fundamental prerequisite for health, well-being, and development and peace. A lot of you know this better than me even, but it built on the pivotal gains and the paradigm shift on sexual and reproductive health and rights that was solidified the year before at the International Conference on Population and Development. The Women's Health Chapter, which Avni also mentioned, retained a central focus on addressing sexual and reproductive health, including maternal health and HIV. And violence against women was also highlighted as a separate area of action. But critically, the Platform for Action went beyond a strict focus on women's health as a biomedical paradigm to underscore the importance of the social determinants of women's health and the need to address power imbalances and deep-seated inequalities that impact on women's health. So here we are 25 years later, or 26 now, and has there been progress? Undeniably. But if the changes we sought had fully materialized, we wouldn't have seen the regressions and the enormous negative impacts for gender equality over the last year of the global COVID-19 pandemic. And the intersection with race, ethnicity, geography, age, class, caste, and poverty has been devastating. So there is absolutely still an agenda for women's rights. And the world and societies have changed dramatically in the past 25 years. And Avni already mentioned a few of these, the many transitions we've seen, including demographic, epidemiological, and socio-economic transitions. Some examples are also the rapidly aging population in many countries where women outlive men, but conversely may have higher morbidity and poorer quality of life. In high fertility settings, the demographic momentum has produced a large cohort of adolescent girls and young women who have very distinct health needs, but who are also facing different social, cultural, and economic realities. Climate change, migration, rapid urbanization, rising socioeconomic inequalities, and political instability also affect women's health and underlying gender dynamics, both in positive and negative ways. But despite all these shifts in the nature of women's health burdens, the shifts in the responses to women's health needs have been slower. So we have spoken already about the large unmet need for several sexual and reproductive health services for women and adolescent girls. And while primary healthcare was flagged in Beijing as a means to improve access, a lot of the service delivery for women's health for the last 25 years has been siloed, vertical, and far from comprehensive. In recent years, fortunately, there has been an increasing recognition of the role and the importance of women as providers of healthcare, both formally and informally. So the figure of 70% of the formal health workforce being women is now widely used to advocate for greater attention to the issues of opportunities for leadership, training, pay gap, conditions of work, and sexual harassment. And at the same time, with decreasing investments in health systems and task shifting, the healthcare burden has shifted to frontline health workers or care providers in households who are mostly women, underpaid or not paid, and have less information, training, and support. Feminist and women's movements were instrumental in Beijing in driving a feminist agenda for women's health that was really centered on the promotion of gender equality. But under the increasing backlash of, from political and rising religious conservatism, feminist movements and the rights-based approach to women's health are under threat. And then, of course, there's the COVID-19 pandemic. So it is against this backdrop that we have been working together on this exciting collaboration with WHO and the BMJ and a group of inspiring authors from every continent to review achievements across a range of priority health areas and open up a revised health agenda that takes into account the new opportunities offered in 2020, 2021 now by technologies, partnerships, and innovations, and the post-COVID world, but also recognizing the new obstacles presented in today's realities. So the intended audience for this collection includes health policymakers and practitioners, but also professional health associations, researchers, and implementers of health programs for and with women in all their diversity. So I invite you to visit the BMJ website to dig into the series and the fascinating analyses and opinion pieces that it contains. And what you'll see now is a first wave of papers, and you can expect a second wave in June. So over to you, Avni.
Thank you, Michelle. I'd like to first invite Asha George to talk about one of the papers that was published in October of last year, focusing on health workers, please. Asha.
Thank you very much, Avni. And I assume I can share my screen. Looks like it. Okay, so can everyone see the slides?
Yes.
Great. Well, I'm delighted to be with you. It's very exciting to be part of this panel and these collaborations highlighting women's health rights, given the trajectory and the historic achievements in Beijing and revisiting them 25 years down the line. So I'm presenting on behalf of my co-authors. It was really wonderful to work with them, colleagues who are at the forefront of evidence at WHO, but also those in academia, and importantly, colleagues who are in ministries of planning and in health departments themselves. All of these partners need to come together to advance gender equality and women's rights in the health workforce. So we pulled together this analysis, and I'm going to present towards the end this image of this iceberg. And so you see it slightly hiding on this slide, but you'll see it more towards the end. It was a way in which to visualize what is all the gender power relations that underpin violence against women health workers. So to give you an introduction, there we go. Beijing 25 years ago was really quite, was progressive in many ways. And it's striking for some to realize that even 25 years ago, Beijing, the program of action recognized women not just as users of healthcare, but as key contributors and producers of health. 25 years later, that recognition has finally reached policy circles. I've worked in the field of human resources for health for a long time, and it was so hard initially to get those working in human resources for health to disaggregate by sex. It's a field that tends to show statistics by profession and not disaggregate further by sex. And so I think for a long time, the fact that the health workforce is predominantly made up by women, but women at the bottom of the health workforce and not enough women in positions of leadership was hidden for a long time. There are other issues in the health workforce, and we chose to highlight violence against women health workers as one topic that has been relatively neglected. And we thought in terms of a forward-looking agenda that this piece would help to highlight the problem and give a different way of looking at violence against women health workers to push the agenda forward a little bit more. It's important to highlight that this violence not only has been ongoing, but even as women have been at the forefront of responding to COVID-19, there have been reported instances, and we've documented them in the paper, of violence against them, even as they're responding, and whether testing, providing ICU services, responding to COVID-19, there have been instances of violence throughout. Our argument is that these are not individual cases, they're not isolated cases, and unless you take a broader gender analysis and analytical perspective, you don't see the underlying structural basis for that violence. And therefore your measures won't be effective if you don't see the whole iceberg that sits under the flashes that are the violence, the incidences of violence. So, drawing on feminist analysis from the Global South, Srilata Batliwala is a key feminist thinker. There's a lot of thinking of power and global health. But she pulled together, we adapted this framework and pulled together these 5 questions to look at what are the what drives the gender inequalities that that underpins violence against women health workers. And I'll be going through them systematically. So let me go with the first one. What is known about the problem? And one of the key issues is that we don't have enough data. This is one area where there's a lot of invisibility that makes it harder to advocate and put the problem on the policy table. We do have surveys and tools that have been developed, but they're not routinely implemented or mainstreamed in, for instance, facility surveys. At the same time, there's a lot of stigmatization also. So there's a lot of lack of reporting in existing mechanisms that could possibly document the issue. Overall, this reflects the lack of investment in acknowledging and documenting women's experiences of being contributors, core contributors to the healthcare sector. So that's one aspect of what hides the problem and makes it hard to work on. Another key way of looking at the gender power relations underpinning this is to look at who has what are the resources that make it harder for women health workers to raise this issue of violence and advocate on their own behalf. One, there's a lack of trusted and independent reporting mechanisms. I know in a study some time ago in India, often in hospitals, it's the top management that sits on some of these committees, and therefore you're reporting against your own hierarchy these cases of sexual harassment and violence. They're not independent often. And even if they are reporting mechanisms, they often don't have any teeth in them. It's striking that in 2019, 59 countries did not have laws prohibiting sexual harassment in the workplace, but more, double the number, had no civil remedies or criminal penalties for sexual harassment in the workplace. This is really striking given what has happened in the Me Too movement and broader recognition of this issue, but actually we've been very slow in changing our laws and our mechanisms to respond to women who are in this situation. COVID-19 has also brought up the issue of protective equipment, and women who are often, for instance, community health workers who are at the bottom of the health workforce. Often we're not given insufficient protective equipment compared to health workers higher up in health facilities or at the top level. So that's one way in which these inequalities manifest. There's been a lot written about how protective equipment is also designed with a male model in mind and how that makes some of the protective equipment not effective as well. So I'm going to pick up the pace. I'm very passionate about this topic, so I can sometimes get a little lost. Second, it's striking. This is a health sector. The health sector is predominantly employs women, yet women don't have equal pay in the health sector. And therefore, if you are, it makes it harder for you to take a position of leadership when you're just trying to survive and bring in your livelihood. The gender pay gap is larger in the health sector than any other health labor sector. That's atrocious. There's a lot of room for improvement. And it's striking in this world also that lots of forms of healthcare are not even paid. So many community health workers are not paid, and the recognition of care at home is also very far behind. There is another major bias in the healthcare sector that makes it hard for women to advocate, to empower them to address issues like violence against women health workers, is the consistent lack of professional recognition and respect for women health care workers. By profession, nursing and midwifery reports to medicine. So there's that structural inequality. And often in many midwifery and nursing associations, medical doctors sit at the top of the nursing association. So that shows the type of power inequalities, and that makes them very hard to have an independent voice. Lastly, and this issue has really in the last 2 years gained policy traction, the fact that women are predominantly, they form the labor for the healthcare sector, but not the leadership. There are more men in the boardrooms than women, and there are very few women who make it to leadership. If they do, they're often not supported. And I think this is really key, because it's not that women leaders are inherently transformative. They need the support, and they need to be held accountable just like anyone else to push the issue of violence against women health workers to the top. So all of this comes together. These things, gender inequality is not, many of these things have been normalized in the health sector. And the key thing to understand is that these things can be changed. There's a lot of room for improvement. And that's why we also use this image of an iceberg, because we can melt the iceberg if we address these currents that are sitting underwater, freezing action. And I think the key thing, number one, we identified 3 actions. One is to do better at naming the problem and understanding it. And looking at alternative ways of framing the problem. We've done really exciting work here in South Africa using film and participatory research to change people's framing of violence against health workers and who women health workers are and the respect we should have for them. Professional associations and regulatory bodies need to have more representative leadership, and they need to lead on this issue. And finally, women health workers themselves, change doesn't happen on its own or by other people. It needs to be claimed by people who are affected by the problem. We need to do more to empower them to find their voice and to support collective action to fight for these changes in the health sector. Without these changes, we will go on with a health workforce that is really not reaching its potential in responding to health, and particularly as we face the challenges of the global pandemic. Thanks very much. I look forward to your questions and comments.
Thank you, Asha. Thank you for raising some very important points. And for me, one of the key takeaways from your presentation was really how patriarchal health systems and health institutions have failed the women health workers in the number of ways you've articulated. I encourage all of you to submit your questions to Asha through the Q&A and hand it over to Veloshni Govender, who will be speaking about the second paper in the BMJ series. Over to you, Veloshni.
So good day to everyone. Good morning, evenings, wherever you are, and thank you for joining us. This is one of the papers that I'll be speaking to that was in the BMJ series on women's health and gender inequalities. And in this paper, together with my co-authors, some of whom are here today, Michelle Remy and Lavanya and Sophie Witter, who's probably not joining us, but is also one of the co-authors. In this paper, we make the argument that employment-based health financing does not support gender equity in universal health coverage. And I think probably I should start my video as well. Sorry, got a bit confused. 2 important definitions to flag at the start. The first is our understanding of universal health coverage. Universal health coverage is one of the targets member states adopted in setting the Sustainable Development Goals in 2015. And UHC, as we commonly refer to it, means that all individuals and communities receive the health services that they need without suffering financial hardship. And this includes the full spectrum of essential and quality health services, from health promotion to prevention, treatment, rehab, and palliative care. And the second important definition to flag up front is what we understand by employment-based health financing, which includes any form of health financing and entitlements to health services that are linked to a person's employment status and type of employment. And type of employment is really, really important, as we will flag and we describe in this paper as you delve deeper into it. Can you go to the next slide? Okay, good. And just to outline, so what I'll cover to this in the next couple of minutes is identify what are the key messages from the paper, and also why it's relevant to the current global context. And the global context we all are well aware of, which Michelle spoke to, and Asha as well, is in terms of the COVID-19 pandemic. Secondly, why is employment status of women in the global market important? And what are the implications of employment-based health entitlements for women's access to health care? And lastly, what are potentially some of the solutions that we can look at that we can explore to address some of these inherent challenges? Go to the next slide. So some of the key messages from the paper, and I think this is important for us to kind of keep at the back in front of our minds. And this is not new, but particularly important when we look at healthcare access. Firstly, that women face more employment insecurity and transitions across their work lives, including for reproduction and unpaid care work. And this is something, unpaid care work, which is also what Asha had also highlighted as particularly important. Women's access to healthcare is threatened, especially when it's linked to their employment status and the terms around employment. And that makes it particularly precarious and can often result in women delaying seeking care when they need it, particularly when there are huge and very high levels of financial costs. And lastly, a key message from this is that gender equitable universal health care reforms are needed to ensure continuity of access to high quality health benefits and financial protection across the life cycle, especially during changing circumstances like we're witnessing now during the pandemic, as well as in normal, ordinary times. We no longer know what is normal after this, but during often the life cycle during work transitions as well. If you can go to the next slide. Again, just to remind ourselves of gender inequalities and gaps in employment. Firstly, when we look at the formal sector, is that the formal sector, women are overrepresented in lower positions, underrepresented in positions of management and leadership. Again, Asha alluded to this, particularly looking at the health sector, but this really holds across all sectors. The pay gap is approximately 20% between men and women, and all of these gaps are wider for women with children. Secondly, when we look at unpaid care work, again, another that's particularly prominent and important for the health sector, is that women perform more than 80% of unpaid care work. And this actually translates into more than 600 million women worldwide that engage in full-time unpaid care. So that really drives home also the important point is, how do we value work, and particularly unpaid care, which is actually so important. Thirdly, what we are seeing now more recently in the past probably 10, 15 years is that women are also more likely to engage in non-standard work. And by non-standard work, we refer to part-time, temporary contracts, crowdsourced work. And non-standard forms of work are especially important when we're looking at healthcare access and even access to broader social security, since it affects all aspects of working conditions, including collective bargaining rights, employment security, wages, working time, occupational safety and health, work-life balance, opportunities for training, as well as social security coverage. And finally, women in low and middle income countries are highly concentrated and tend to be more concentrated in the informal sector work. And this translates into lower pay and less regular sources of income. And often these women have very poor access to social protection. They also have a lower ability to make regular contributions to informal health sector for employment help schemes as well. And overall, these translate into women being more vulnerable than men. And these inequalities in unemployment are overall bad for access to social security, in the long-term retirement earnings, as well as healthcare and health outcomes. And what we do know from the literature, this is not necessarily specific to employment-based health insurance schemes, but more generally is that when there are barriers in terms of health financing, is that there are delays in seeking care. And we know that because of gender and specific gender norms, that women may typically forego their own health needs and place higher priority in terms of household needs as well. Can we go to the next slide? So why are employment-based health entitlements a problem, and why is it especially a problem for women? I just want to draw your attention to 2 points on this slide. Firstly, there are differences between full-time paid work and those with non-standard work and in the informal sector. So for those and for women in full-time paid work, they may receive better and different healthcare benefits compared to others. And also for unpaid care work and non-standard work, it's often not valued, does not necessarily have the same kind of levels of recognition as the extent of full-time paid work. And women who are dependents, women as non-standard workers, tend to receive lower levels of healthcare access through other, if it's through public or mandatory schemes, compared to women who are in full-time paid work. So this is just the gender differentials amongst women themselves. In the paper itself, there are examples from actual country settings that speak to some of this. So you can always just delve into that when you have a chance to look through the paper. And secondly, as we are unfortunately witnessing as this pandemic continues to unfold, is that schemes that link women's health entitlements to health services and links it to employment actually creates conditions of discontinuity to high quality healthcare access, especially when there are changes to work status or in terms of the arrangements. So women tend to have more fragmented careers over their life course due to well-established reasons of reproduction, care work, voluntary and involuntary unemployment. And so overall, what can we conclude from this? What can we, conclude from these findings? Is that firstly, is employment-based health financing systems that link women's health entitlements to their employment status, the types and the contributions do not support gender equity in universal health coverage, because the existing work inequalities women face can translate into inequalities of healthcare access. And in the current context, again, the recession has had important economic gender dimensions, which are being well documented. The pandemic's toll on employment is heavier for women, and globally, women's jobs losses due to COVID-19 are almost twice as high compared to men. So over the past year, and this is data coming from the United States, is millions of people have lost employment, and that means having lost access to healthcare. And they will likely remain uninsured unless their circumstances change. And this really drives home the fact that employment-based systems are unstable, they are inequitable, and they're fragmented, especially during an economic crisis. So if you can just go to the last slide, please. Thanks. Since employment-based schemes are a problem for gender inequity in UHC, and I think maybe to also emphasize that employment-based schemes are a problem, full stop. They're just worse when we consider the gender dimensions, and they amplify the negative aspects for women. So what are the policy solutions? So firstly, it is important to advocate for universal healthcare entitlements. And the basic message here is that health financing should be predominantly made through taxes and prepayment schemes. This would include removing user fees in settings where there are still user fees and reducing the financial barriers to access. And this is especially important for women, as we've noted, is that such a high percentage or proportion of women are particularly in low and middle income countries, located in the informal economy and increasingly in non-standard work, where the entitlements are hugely unequal. And in settings with existing employment-based systems, is de-linking the health entitlements to services from direct contributions. And where there are multiple parallel schemes in place, is to try and advocate that the benefits, the levels of financial protection are equal and ensure equity amongst different schemes. Thirdly, and I think this is really broadly for wider social protection as well as for UHC, is to advocate for gender equity to guide and address underlying gender biases and discrimination in UHC design and policy reforms. And this would include how we look at design benefit packages, pricing based on, on gender as well. And importantly is valuing unpaid care work compared to other types of employment. So as an example, and there has been some progress in this respect, in 2012, the EU established a ban on gender discrimination pricing strategies in health financing plans. So there have been precedences in terms of this. And lastly is to strengthen the evidence base. And I particularly like Asha's analogy of the iceberg and using that as a frame of reference for being able to dig deeper and understanding what are the questions around employment arrangements, and particularly looking at the questions around intersectionality. We know that there are differences between different types of employment. These translate into differences in terms of education, income, and a whole various other range of stratifications that are relevant. And I think it's important to be able to advocate for gender equality, which is we need just a lot stronger evidence from different settings. Thank you.
Thank you very much, Viloshini. For me, one of the key takeaways from Viloshini's presentation really was the fact that employment-based health financing fails to take into account the precarious nature of the work that women do. With this, I'm going to ask Lavanya Vijayasingham to share the third paper that was in the BMJ series. Over to you, Lavanya.
Well, thank you, Avni, and hello, everyone from warm Kuala Lumpur. I'd like to take a moment to acknowledge my co-authors, and I present this paper on all our behalves. So, making sure that women and girls are able to use safe and effective medicines all through their lives is not only about the financing and access systems. It is also about product research and development, regulation, and commercialization. Women and men, as biological females and males, are biologically different. They present different disease risks, symptoms, clinical signs, and levels of severity. And this is the case with men's higher severity of acute COVID-19 infections and women's disproportionate experience of long COVID. Biological sex also influences how pharmaceuticals interact with the human body, such as its rate of absorption and its movement through the body, and importantly, the levels of outcomes it induces. And this has implications on the safety and efficacy of products. And so this is not new information. This has been established for quite a while now and across multiple therapeutic areas. However, knowledge of this is perhaps not mainstream enough, and the consequent motivations to act on these differences, well, it can be better. Females have been excluded from pharmaceutical research, and we're still not often well considered enough on account of safety, cost, complexity, such as from factoring in our hormonal cycles, and an overall male bias of the human body. And this, in fact, was flagged in the Beijing conference all those years ago. There has been some positive regulatory shifts over the past 20 to 30 years, and I invite you to refer to the appendix section of our paper for more details on this. However, there are still notable gaps in practice. So in the preclinical stage, there's still a long way to go with the use and the reporting of outcomes in both male and female animals. In clinical trials globally, women's general representation has been improving, but similar to preclinical studies, we have problems convincing scientists to analyze and report the data by sex, even if there's no difference. There are also recent trials that have purposefully left out females, and an example of this is the Discover trial for Descovy, a pre-exposure prophylaxis medicine that was approved in the US only for use by males. We also have to do better at representing women at different stages in life, such as elderly women, lactating, and pregnant women. Again, with COVID-19 vaccines, we are seeing how pregnant frontliners face ambiguous messaging and a lack of safety data to inform their vaccination decision. But thankfully, companies are now responding and are organizing phase 4 trials to get this formal data. In regulations, we still have a problem with enforcement, variability in decision-making, and an overall understanding of the importance of sex and gender. So this is a pretty old story now, but I think it demonstrates a bias in regulatory decision-making. Regulators in Japan and the USA took years to approve contraception and the medical pill for women, but both countries expedited approval for Viagra in just 6 months so that it could reach men in a timely manner. There's also little research on the sex differences in the economic value assessments. But in theory, the differences in health outcomes can technically influence the value profiles and consequently decisions on its inclusion in national insurance packages and hospital formularies. And once products are approved and are on the market, women are generally known to experience and report more adverse events that require hospitalization. And again, with COVID-19 vaccines, crude early data is suggesting that women are experiencing a higher number of serious and non-serious adverse events, a trend that has also been observed with other past vaccines, such as for influenza. So in short, there's still a distance to go. So how can we make pharmaceutical research and regulations work better for women? Here are some solutions we propose. So 1, regulatory policies and practice. Well, there's a need for stronger recognition, capacity, and power to change the status quo. Indeed, capacity and awareness building through training, dialogues, and frequent reminders can help. As we speak, one of our co-authors, Kara, is delivering a training session for regulatory scientists who review submissions across the product lifecycle for Health Canada. More of such sessions across different countries and regulatory settings can be beneficial. We can also learn from countries like Japan on how they have shaped industry practice through requests for local trial data and where non-compliance does result in undesired consequences, such as delays or non-approvals of products and indications. 2, evidence generation, research funding, and reporting. Scientists, funders, and journal editors need to be more serious. Please do not fund or publish research that does not disaggregate, report, or discuss sex and gender considerations. Make this reporting non-optional. And update checklists such as the consort using existing guidelines such as the SAGE, the Sex and Gender Equity in Research guidelines as reference for what is important. 3, commercialization and industry prioritization of future products. Well, we are not going to achieve any improvements without engagement and collaboration with industry stakeholders. We need to have open, early, and frequent conversations to change the narratives and perceptions about sex and gender. And importantly, let us stop formulating commercial strategies and industry research priorities that build on and extend gender inequity and inequalities. For example, the pursuit of high-cost interventions For women, disproportionate conditions such as breast cancer and autoimmune conditions still block women's access. Perhaps we can change practice through commercial incentives, such as those used to encourage investments in rare diseases therapeutics. And across the three areas, let us talk about who is at the table not addressing these gaps. We need more women leadership and decision-making positions who will further support and implement these actions. And so just on a final note, I want to remind everyone that the consequences of not acting quickly and in solidarity to counter the lack of awareness and any resistance to act is that we continue to compromise women's access to timely, safe, and quality of life enhancing therapeutic options across the lives. Thank you for your time.
Thank you, Lavanya. Very, very useful and powerful call to action here. To me, one of the things that struck me most in your paper was really the fact that, we as researchers and scientists have really failed to take into account both biological sex and gender into the research process. And this has not only compromised the quality of the scientific outputs, both for health and public health, but also obviously reflects a gender bias, a male bias among scientists, among researchers, and among the research institutions. And that really has a big call to action. So with this, I'm going to hand it over to Rachel Hinton, who's with the BMJ, to deliver some closing remarks before we throw it open for a Q&A. Over to you, Rachel.
Great, thank you very much, Avni. And as Avni said, I had the absolute pleasure of working with Paul Simpson, the international editor at the BMJ, and with all the presenters here today and their co-authors to publish their papers as part of this really timely and important series. Would really encourage you all to read the collection about why the issues discussed here, as well as other issues discussed in topical opinion pieces, are really important, and particularly the strategies and actions that have been discussed here today to advance women's health and gender equality. You know, there's great examples provided from around the world, and you may also come away with a few snippets for future talks and presentations, which is always a good thing as well. So, but as editors, you know, we really have a good opportunity to learn about and consider really important ideas, such as many of those discussed today and across the series. In this case, related to really moving beyond business as usual approaches to dealing with and changing these, you know, inherent gender biases and rights violations and discrimination against women. We've heard and seen how these biases affect who gets what, such as employment-based financing systems disadvantage women, and how male bias impacts pharmaceutical research and regulation, as we've just really heard brilliantly now, and which continues to contribute to the exclusion of women. And first today, we from Asha and colleagues, we heard about violence against women, and in this case, health workers, and it's a you know, terrible reflection of this bias and discrimination, and we need to think about gender through the lens of power and you know, the iceberg approach, because as we've seen today, you know, gender power imbalances underpin, you know, the issues in the other papers as well. Who makes the decision with research? Who gets what with healthcare entitlements? So this interconnectedness of the papers is really clear from the discussions today as well. And ever more so, of course, the gendered effects of the COVID-19 crisis that has been brought up today in terms of unequal care burden, impact on female health workers, employment issues related to, as we've just heard, pregnant women and COVID-19 vaccine trials. So, you know, it's also that the pandemic has also really thrown into sharp relief, I think, that gender inequity still exists, you know, clearly for women in science and medicine, as well as academic publishing. You know, we saw the first signs of, you know, such sex imbalances in the overwhelmingly male lineups of experts speaking on COVID-19, you know, the poor representation of women on government pandemic advisory panels. But as journals, including the BMJ and our speciality journals, you know, we've seen a really worrying drop in the proportion of female authors of research papers. So as the BMJ, you know, and other journals, but you know, we're challenged to commit to policies, I think, and guidelines that better enable better representation, I should say, of women in our publications and structures. You know, as Asha eloquently, you know, described, as you know, people are in positions of power, and as journal editors, as you know, we are potential gatekeepers of who we work with, who gets published, how data is, you know, the segregation of data, as we've heard about, who we ask to write, who makes decisions, who reviews. So thinking about gender through this kind of lens really helps us recognize our own power and also how to share it. And I think it's one of the driving reasons that the BMJ was super keen to be involved in this project, because as well as being part of perhaps the problem, we're also hopefully part of the solution. You know, importantly, I think, and the BMJ is the first, wasn't the first medical journal, I should say, to have a female editor-in-chief, but the BMJ certainly has the longest running editor-in-chief. And Fiona is currently the only female editor, I think, of a major medical journal, which is great. But at the same time, one must understand the systematic bias, perhaps, that's still built into the system of publishing, as has been perhaps raised today and before. So, for example, the BMJ doesn't have a gender balanced editorial board. There's issues perhaps, you know, as been raised around disaggregated data. You know, do we invite equal numbers of men and women as peer reviewings? We have to make sure we don't commission all male lineups when it comes to doing collections such as the one today we're discussing today. So pleasingly, and it's great to know that and see that the BMJ is making changes to promote gender equity across the BMJ. And I'll put a link to a paper where we've put out 10 resolutions so far to do that. And I'll share the link in the chat box after so we can really start to interrogate some of these issues and the structures that we work within, and change them within the organization itself and within our publications. You know, we have a choice, I think, about, you know, which voices we platform, and we need to, you know, make those choices consciously and conscientiously, you know, whether it's around gender or whether it's around work from the global south, more and the more intersectional underrepresented voices. So this is a start. Clearly, you know, we certainly don't have all the answers, and we openly admit that while making progress, perhaps compared with other journals, in terms of, say, female leadership and committing to addressing gender equity through this new resolutions and what it would like to do. It takes time, commitment, clearly resources are needed, and the collective will, I think, has been raised today, as well as the belief that there is a better way of doing things better. And all the papers today, and I reiterate it from our perspective too, is that leadership for the issue needs to come from the top. And as I've said, the collection of articles certainly reflect that. And I'd just like to say we hope the BMJ can be a platform with this series, and in a small way do what it can to champion and support these efforts, particularly through this collection, but recognizing there's still very much more to do. So just to end, I'd just like to say, you know, we're absolutely thrilled to have been able to work on this collection. I hope you all dig into it and see what an impressive piece of work it is. It's got really hard-hitting articles, such as those today. There's opinion pieces and that are shorter and focus on other issues. And there's more to come, as I think Michelle mentioned as well, in June, which is an exciting thing to look out for. But what's good about these papers and the discussion today is that they reflect, really what's happening around the world, but they're about changing the default. I think, changing the discourse, changing the way we do things. So with that, I really want to thank all the authors who contributed to the series, particularly those speaking today and their co-authors. Absolutely, the UNU and WHO for bringing this really important work to the BMJ. Where we see the challenge, we have this platform. We hope we have this starting point, and that we as the BMJ can continue to work with you and others to catalyze and energize the conversation, as we all know it's important for women's health and populations more broadly. So I'll leave it there, Avni, and hand it back to you. Thank you.
Thanks so much, Rachel, and for your call to action for so many of us. I wanted to open uh, the panel for questions. So over to all of you for your questions and comments. Maybe I'll start. If I don't see any raise hands so far, but maybe I can start with some that have been posed in the Q&A function. The first one is for Asha. Asha, do you think gendered hierarchies in the healthcare profession can be changed through move towards intra-professional practice? And if yes, do you see any examples of where this is yielding positive results for health workers as well as for patients?
Thank you very much. So I think this is really, I really want to thank the respondent for the question. But I personally don't know, and I think it's an area for further investigation. There are many exciting innovations in the health workforce, but the key question is, have they been evaluated based on this gender lens?
Thanks, Asha. So the next question that is come through the Q&A is for Viloshni. Viloshni, do you have any? Oh, it disappeared. Maybe it was answered by Viloshni in the Q&A.
I did
Did you
answer a
answer
couple
it
of them.
already? Oh, okay. So,
Hopefully the answer satisfactory.
okay, so in that case, I'm going to move to the ones who've raised their hands. I'd like to invite Farhadiba Tenril Lemba. If you can unmute yourself and pose your question to the panelists.
Hi. Okay. Thank you for the opportunity. My name is Farhadiba. I'm from Indonesian Women Breastfeeding Associations. So I was, can you hear me? Okay.
Yes,
All
please
right.
go ahead.
Yeah. Feloshni, how about maternity leaves? I know that every country has different regulations on the length and the paid leave, yeah? Do you mind explain more about that? Because what happened in the world is, or especially in my country, every lactating mother forced to come back to work, yeah, let's say not even a month after their delivery. Therefore, they're, failed to breastfeed their kids and soon replaced by formula. Although we know that breastfeeding is the best. So what do you comment on that? Thank you.
Thanks for your question, Fardiba. I'm not an expert on labor practices, but clearly from a woman's perspective, those are highly unequal, unfair practices. And I think it obviously kind of spills over into broader social security and employment and labor reforms that are necessary to kind of close some of these gender gaps. And I think I think what we see often, not always, but there seems to be some kind of not a correlation between regressive employment practices, gender regressive employment practices, and access to health insurance and employment base. So there tends to be, we can often see, these patterns. And I think there was another question, and I'm not going to be able to answer your question specifically on the virtues of breastfeeding versus formula feed. And I won't share with you my own personal experiences around that, but I'm an advocate and I support breastfeeding. But I think what we do see, in countries, and this is from a webinar we held last week on access to UHC and integrating sexual and reproductive health more comprehensively in UHC. And the experience from Sweden, and it's not necessarily unique to Sweden, but Sweden is a good example, where with delinking employment access to healthcare is dealing from employment, is also supported by broader gender equality policies and reforms, paternity care, longer, way more progressive maternal health, maternal health benefits, provision for facilities in the workplace for women to be able to breastfeed when they need to, access to contraception, even in the workplace, have access to menstruation pads, or any. So I think it's often where access to healthcare is supported by more progressive social protection, including labor and employment benefits. So I think, and I think it comes back to some of the other questions, is being able to, these are not single issues, and being able to frame them in terms of a broader agenda for gender equality. And I think I'll stop there. Maybe some of my colleagues on the panel might be able to chip in as well.
Just briefly, I think I'm struck that we make assumptions that health workers have labor rights. And I know particularly, for instance, coming from India in the private sector, there are a lot of nurses working in a very unregulated sector. And we make assumptions that, because they're health workers, they should have access to healthcare, paid leave, maternity leave. Many of these things are not necessarily there. And I think having it would be great to have a type of employment scorecard in which we could, in addition of measuring quality of care and services, do private hospitals themselves respect the health workers who are working in those hospitals. So just one crazy idea, but it is striking how much what happens in the healthcare sector sometimes. And we should be able to reward those who are at the forefront of providing better work environments, because that will lead to better quality of care if you have health workers who are not tired, underpaid, and resentful themselves. Thank you.
Thanks, Sasha. There is one question coming from Amy McDonald. Amy, if you're online, feel free to add to the question, but the question is, are there any countries where we see less gender inequality or healthcare which is more geared towards gender equality? Amy, would you like to clarify this question, who it's directed for, or add to the question itself?
Hi, can you hear me?
Yes.
Yeah, hello. Yeah, I was
Please go
just
ahead.
obviously we've been talking a lot about things such as maternity and the fluctuation of women in employment. And I mean, I come from the UK, and I think our healthcare system at the moment is I would imagine quite fair because it's the NHS, so it's free and it's government based, but we are moving towards privatisation. And so I was just wondering, do we have any sort of blueprints where we can see that the healthcare systems are really being built around understanding the fluctuation in women's roles and how we can sort of safeguard that? Are there any examples of countries that are doing it really well?
So maybe I can just, I don't think we have a scorecard per se, but there are issues where there is much more, there has been progress made. And I think, for instance, the issue of respectful maternity care. It's not only on the policy agenda, but there have been collaborations with governments to reform what are key interventions to change the way government services are organized to improve the conditions in which women labor and deliver children. There are, for instance, I know Avni has led a lot of work by WHO on getting the health sector to respond to violence against women. So that there's been a whole range of partnerships with certain key governments leading on that. So there are probably on key issues, particular initiatives. I know, for instance, for a long time, the government of Mozambique has had a very strong gender policy. But we don't have a mapping, for instance, across ministries of health. What are ministries of health that have gender policies? And no one is tracking that. So I think there's huge opportunity in this area because the baseline is very low. But there has been significant progress on certain key initiatives. So once you break it down into those issues, it's easier to measure progress. Others can comment as well.
Maybe just to add to that, I was kind of scratching my head as you're speaking, Asha. You know, because it's not, like you said, we don't necessarily have a scorecard. And I think probably maybe to also raise it, there have been some countries that have made, you know, considerable progress in striving towards universal health coverage. I mean, I don't think any country can claim that they have, but they made considerable progress, and in some instances, not necessarily with a commitment to gender equality. But so Thailand would be one example. But I think more recently, I mean, you spoke of Mozambique, I thought of Rwanda, with very strong commitments to gender equality, women in positions of leadership in the public sector. But I think this is also translated into their health systems reforms. But I can't, you know, speak to any particular area where this has been particularly strong. But there's been a broader commitment to gender equality more broadly.
I have a few questions while I wait for other questions to come through. There are a few questions that were actually sent to us as part of the registration, and several of them had sent questions ahead of time. So I'm going to actually direct some of those questions that came in ahead of time to the panelists. There is one question which is about, to what extent have countries achieved success in achieving the targets for the Sustainable Development Goal 5 related to gender equality, and what are the areas that have been particularly challenging? Would any of the panelists like to take this on? This was not directed to any of the panelists, but it was submitted ahead of time. A big grand question. So any examples?
Maybe I'll kick off because we started discussing this. I think there's been a lot of progress in some areas. For instance, we were talking about in the areas of education, there's been progress. I wrote a paper with Avni and I was struck that, and even in health, there's been a lot of progress compared to other sectors. What we don't know is a lot of the measures of measuring progress often is based on surveys that have a recall period that you're actually looking at something that happened 2 years ago or a year, you know, in the past. And I think the big question is how COVID-19 has affected the progress that has been measured. And I think a part of COVID-19 is also reflecting how not only how globalized our economies are, but also highlighting the informal nature of a lot of the labor force, not just in health. And that has implications for women. And I think it was striking to me to see that, yes, we have more women who are in employment, but they are in often in employment where they're underpaid or in informal circumstances. So there's been great strides in political representation, not necessarily by countries in the global north. I have to say, when you look at the World Economic Forum, has also does a report card every year on some of these indicators. But the big question is what the impact of COVID-19 and how regressive that's been, and actually taking stock of that. I don't know if Michelle or Lavanya or others or Rachel want to take a stab at this grand question.
Maybe I can also add a couple of points. I think if you look at some of the SDG Goal 5 indicators, in some regions, for example, notably in South Asia, we have, for example, seen drops in child and early marriage. So that, if you look at progress from that perspective, in some regions, yes, child and early marriage progress has been made on that. But on the other hand, we've also seen increases in child and early marriage in Latin America. So it's really a question of looking at the glass half full, glass half empty. Another area where progress has been made is in girls' primary education, which was one of the MDG targets, but less maybe progress, and particularly in some countries and regions on secondary education for girls. And if you look at not just uptake of secondary education for girls, but school completion rates. There are huge dropouts, for example, and continue to be huge dropouts for girls when it comes to secondary education. A third area where we've seen some progress again, but also looking at the rates, is violence against women. More and more countries are collecting the data on violence against women, but as WHO and interagency new estimates show, the scale of violence against women remains unchanged for almost a decade, and it's frighteningly high. Almost 1 in 3 women have experienced both partner violence and or non-partner sexual violence. And this is still, as to use Asha's figure, it's still the tip of the iceberg, because we're not measuring sexual harassment, we're not measuring other forms of violence. So yes, progress has been made, but it has, I think, slow. It's been unequal in some regions more than others, and probably I would say, and reinforcing what Asha is saying, that COVID has probably undone some of that progress, and the extent to which it has undone that progress will probably only come to know in the coming years.
And maybe one thing I can add,
yeah.
or Michelle, you want to add?
There was just one thing I wanted to add in the glass half full or not, the other way around probably, is on the norms side. I mean, although we have seen that in some areas norms can actually change relatively quickly, in terms of the unpaid care work and the sharing of responsibilities of unpaid care in the household, that has been surprisingly stagnant, and we've seen very little change in that area, even though it has come coupled with women increasing their labor force participation, primarily in the informal labor force. But yes, that shift on in the home side of things has not really materialized as much as many would think.
Yeah, and just to back that up, and what Avni and Michelle said, is progress for women's health and gender equality is contested. Progress, it's not the arc of progress is slow. It is on a determined path, but at every step it's more complicated than other areas, because there's not always agreement, and I think there have been amazing changes in discourse, and I think there have been new developments in this field. One contested area is also male engagement and how programs have evolved, and in some ways not enough progress has been made. But also conservative political parties can be led by women. So I think it is an area that requires concerted social mobilization and at CSW, feminist movements to keep all of us to, what is that expression? Keep our toes on fire or our feet to the fire to hold us accountable. And time and again, we need to bring these issues to the media and make noise about it to push for more progress.
Thank you, Asha. I see a raised hand from Wangari Tharao. Please go ahead. Wangari.
Good morning, afternoon, evening, everybody. My name is Wangari Tharao, and I work in Toronto, Canada. I'd first like to thank the presenters for such illuminating presentations, as well as the discussions that are happening now. One of the things, first question I would like to ask is, can we get the presentations from the presenters? The second question is, I work with racialized women in Toronto who have migrated from Africa, the Caribbean, Latin America, and South Asian communities. And we know for a long time the inequities that actually exist between different populations of women. But when we talk about women and sex and gender, we don't disaggregate data by race to understand what is happening with racialized women or with trans women, and any other intersectional dimensions you will think about. And I, particularly if you live in the global north, the inequities between different groups of women are very, very evident. And COVID-19 has actually brought this above ground. In Toronto, majority of people who actually got COVID were actually from racialized populations. And about 83%, as well as a disproportionate number of deaths were among racialized communities, and in particular, women. And I'm wondering if the presenters could actually comment about this, and where, when you think about equality and fighting for gender equality, where these women are located within the perspectives you were all presenting about. Thank you very much.
Would anyone like to respond to this issue of intersectionality?
Sure, I could. I mean, I think it speaks to one of the questions we looked at, is that around healthcare access. And Wangari, I think you mentioned that you are in Canada, which we know is recognized for having a very publicly accessible healthcare system that's based on equity. And I think it raises important questions that, and I think this also goes back to an earlier question, I think was from the UK around the NHS, is that publicly funded health systems themselves are a step in the right direction. But it doesn't mean that access is automatic for everyone who needs it. And that access is also very much mediated by other dimensions around equity. So, you know, and I think what you've raised are, and there could be other barriers in what is on the face of it, an equitable healthcare system with no financial barriers to access. So it kind of begs the question, again, coming back to Asha, I think everybody loves the iceberg, is, you know, what's under that iceberg and what lies beneath and what do we see on the surface? and questions around, how does race, how does migrant status, possibly questions around language access, cultural barriers, the presence of interpreters to be able to interpret the needs and to be the voice between the healthcare system and those who are newly, beneficiaries who do not necessarily understand the system itself. So I think the question around intersectionality is such an important one. That and I think it's important to be able to look at these questions really again in the context of COVID, which has kind of raised the lid on how we see and how we understand healthcare access, not just because of questions around where there were potential lockdowns, but when resources are constrained and who has the ability be able to make claims on those. And and the social hierarchies within societies then interface with other dimensions around access, and that impacts on how people are able to access care when they need it. Even in societies where gender equality, universal health coverage is fairly progressive.
Can't talk
Yeah.
about the health workforce without talking about race and class, and particularly in high-income countries, a huge part of the health workforce is made up of migrants, particularly women of color. And if you look at the statistics of migration, it was nurses who, in the last few decades, they are the health workforce that's migrating across boundaries. And often, once they're in a high-income country, end up working in positions that are much lower than their qualifications because they're migrants. So there are layers and layers of discrimination. I was going to say, in India, you can't talk about these issues without talking about caste. In South Africa, race is very much part of the discussion. And I can send around the resource. Tanya Jacobs, who's on this call, sent a policy analysis looking at even the research on violence against women in South Africa. And what, if you take a perspective on race, what does that say about the implicit things we're saying about racial inequality in this country, and who does research on whom, and how does that bias how we look at a problem? So I think an intersectionality perspective is absolutely essential in the work that we do. Thanks.
Thank you. We've come to the end of the panel discussion. It's been quite a rich discussion and a lot of learning. I just wanted to maybe point to a few things that for me that I was particularly struck by in the conversations we've had in this panel. The first was really about the need to make visible what is not measured. A lot of what we are seeing is the invisibilization of women's health needs. Whether it's unpaid care work, the nature of sexual harassment that women health workers face, specifically, making that visible through measurement and data is, I think, a real strong call to action from this. The second, I think, is really from Asha's paper, but we've known this, through the feminist movement, is facilitating the voice of women health workers and women in general into these institutions through collective action, and then really making health decision makers accountable to what is being voiced, what is being articulated, and to action. I think the other thing that I was struck by, and particularly from Viloshni's paper, was the importance of beginning to value unpaid care work. If we don't value unpaid care work, we really miss out on the needs of women in the workforce. The next thing I think is really, and this has come through for COVID especially, is how we need to have social protection measures in place, particularly in moments of crisis like COVID. Where millions of women have lost their jobs, millions of women have dropped out of the health workforce because of unpaid care work. So we really need to have, during these precarious moments and times, social protection measures in place. I think Veloshni's paper also talks about the fact that universal health coverage has to make sure that entitlements, benefits, and packages for women are in place, taking into account women's health needs. Lavanya's paper was really instrumental in highlighting the biases we face in the medical research institutions, in the health research institutions. We need to make sure that sex and gender issues are enforced through research funding, that they are enforced when research gets published, and when these products, drugs, pharmaceuticals, etc., go through the regulatory processes. And we need to target those institutions to make sure that they are more sensitive to sex and gender issues. We need to also work with the private sector and the industry that is funding and commissioning all of this research and incentivize them to take into account sex and gender issues. Perhaps the one that came through across all of the papers was the importance of having women leaders in all of these institutions and driving change, but also the importance of not forgetting that even as we look at women as a whole, that there are important differences based on race, ethnicity, gender identity, sexual orientation, age, disability, and we need to be uh, mindful of those intersecting forms of discrimination and really take into account the needs of this. So with this, I'd like to really thank all of the panelists, all of the co-authors of the papers, and really thank also the BMJ for giving us space to have these papers published, as well as to UNU for a wonderful collaboration on this series. Thank you to everyone for your active engagement, and wishing you a good afternoon from Geneva, or a good night, or a rest of the morning. Thank you very much, and bye.